So it's 1 p.m. And I'd like to hand you over to Dean Akola Lewis Cameron to do the official welcome. So Dean Akola Lewis Cameron.
Thank you very much, Dr. Wallace, and ladies and gentlemen and students, colleagues. We want to officially welcome you to the first of many seminars to come, dealing with several different topics that will be of interest to you as our students. We know that during this time, we are in different times, and so having to operate in a virtual environment has its own norms and rules and anxieties and so forth. And so we felt that it's important that we treat with this all-important topic of depression and anxiety at this time, at the start of your academic year, because you become lonely, it's a lot of work, and so we want you to be well equipped with the tools that are necessary to help you along this journey. And this is just one of the areas that we want to cover. And we will be having at least about 2 of these types of sessions per semester. So we want you to remain connected, remain tuned in as we share with you from different experts in various areas who will share with us on really just giving us some tools to take us through the academic year. And so starting us off is Dr. Hazel Othello, and of course Dr. Wallace will do the necessary introductions. But I just want to personally thank you, Hazel, for again joining us and agreeing to do this seminar. I know you were with us, would have been, was it last year? Yes, it would have been last year, yes, in that face-to-face session, and the feedback was excellent, and we thought, you know, to do this again. And so we're very, very happy that you agreed to come and share with our students again on this important topic. So students, I trust that you know you have some questions or some comments that you'd want to make at the end, and so we are really open. This is your time, and we are open to all the questions that you may have, and as we treat with this issue of depression and anxiety. So welcome, and I want to hand you over to Wendell Wallace now, who will introduce our speaker for today. Wendell?
Thank you very much, Dean Lewis Cameron, for welcoming Dr. Othello and all the participants to this afternoon seminar. Before I introduce our feature speaker, Dr. Hazel Othello, I'd like to thank the Dean, because this is an initiative of the Dean. Our Dean in the Faculty of Social Sciences is very much student-focused and student-oriented, and she has decided that we need to put these sessions on to assist our students because we are in a new normal, and what obtained before, we simply cannot persist with that. So on that regard, I'd like to say thank you very much, Dean Lewis Cameron, for ensuring and for persisting that we put these sessions on, which will be down to the benefit of the students, and not only to our students, but also to our staff, because we have staff members who are logged on as well. So thank you very much, Dean Lewis Cameron. I'd like to introduce Dr. Hazel Othello to you. Dr. Hazel Othello is a psychiatrist who holds a host of qualifications from the University of the West Indies, St. Augustine, and King's College, University of London, England. Dr. Othello is a registered member of the Medical Board of Trinidad and Tobago, a member of the American Psychiatric Association, a member of the General Medical Council, United Kingdom, as well as a member of the International Fellow of the American Psychiatric Association. Dr. Othello has provided numerous medical reports to the courts in Trinidad and Tobago, St. Lucia, and the Cayman Islands, as well as in other Caribbean jurisdictions, if I may add. She has also given evidence in criminal cases in many of these jurisdictions as an expert witness for the prosecution, as well as for the defense in other cases. Instructively, Dr. Othello has held several posts in Trinidad and Tobago. I'll give you just a few because she has held several positions. She has been the acting medical director at the St. Anne's Hospital, medical director, St. Anne's Hospital, acting chief of staff at St. Anne's Hospital as well. She has been a consultant psychiatrist at the Cayman Island Health Services Authority, as well as the Golden Hope Hospital in Castries, St. Lucia. As of November 2019, Dr. Othello is employed as the Director of Mental Health at the Ministry of Health in Trinidad and Tobago. Importantly, Dr. Othello is also the worship leader at the New Covenant Ministries in Diamond Village, where the pastor is Reverend Fitzroy Othello, who is her father. With that said, we have chosen someone who has much worth, a well-rounded individual who has a plethora of experience and who can share her experience with you in a meaningful way. I trust that you will make very good use of the information that is being provided. So Dr. Othello, thank you so much for being here and for sharing with my students and with the staff. And I now hand over to you.
Good afternoon, students, faculty, everyone who is logged in this afternoon. I hope this presentation will be helpful to you. I will be speaking, as was said before, on the subject of depression and anxiety, and it's very important to speak on that subject at this time, as was said by your dean. We're living in a time when globally reports are being forwarded towards us that many countries are seeing increased levels of depression and anxiety. The research is ongoing and the public papers are being published, and we're beginning to see it in black and white. We knew it would happen. We kind of, it was expected, but we're actually seeing the documented, the articles documenting that it is in fact happening. So it's a time when we need to be aware, we need to be mindful of what we can do to protect ourselves. In the next week or so, we'll be celebrating World Mental Health Day, and this year's theme focuses on greater investment in mental health, acknowledging that in a time like this, we have to prepare for the future where mental health is concerned, and we have to prepare for the onslaught of, we have to prepare in such a way that we could prevent adverse outcomes. So I'll go straight into my topic. What's happening? My slide is not moving. Oh. Okay, got it, sorry. Okay, so what is mental health? The World Health Organization's definition of mental health is that it's a state of complete physical, mental, and social well-being, and not merely the absence of disease. So it's very important to know that when we're talking about, in fact, that's the definition of health. When we're talking about health, we're not talking about the absence of a diagnosis. We're talking about a state of general well-being. And with respect to mental health specifically, the definition from the World Health Organization is that mental health is a state of well-being in which every individual realizes his or her own potential, can cope with normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. The importance of that definition is that it acknowledges that there will be stresses in life, but it recognizes good mental health as a state where, in spite of those stresses, we can feel well, we can realize our potential, we can be fruitful and productive, we can contribute. The other side of health is illness and disability, and the World Health Organization defines disability as any short-term or long-term health loss due to a particular cause. And that cause could be a physical illness, it could be a mental illness, it could be a substance-induced disorder, it could be an accident. Anything that gets in the way of your health can produce disability. And what kinds of things are we talking about? We're talking about physical illnesses, but you could also have disabilities as a result of mental illnesses. And this slide shows you a list of some of the most common mental illnesses. And as you see, mood disorders such as depression are at the top of the list because they are the ones that happen most frequently. Skip past schizophrenia, that is next on the list. And then you see anxiety disorders, which is the third most common type of disorder. So that the topics I've been asked to speak about are actually very, very prevalent, and they're right up there among the most prevalent mental health disorders. I want to go across a little bit to talk about the impact of ill health, because it's very important that you understand that this has a global impact. When we talk about, you know, we like to think about mental health in terms of how it may affect me, but the impact is felt globally. And when we want to discuss that, we use the term the Disability Adjusted Life Year, or DALY, DALY. And it's a term used to describe, to quantify disability. And it really looks at the number of years lost prematurely due to death as a result of a particular illness, and the years lost, even though the person is alive, due to their disability. So the Disability Adjusted Life Year calculates both, adds them together, and comes up with a value, which really is equivalent. One Disability Adjusted Life Year is equivalent to one lost year of healthy life. So you may be wondering, why am I talking about that? Well, it's important in order to understand that this is a global problem. The term Disability Adjusted Life Year wasn't even developed by psychiatrists. It was developed by economists from the World Bank and later adopted by the World Health Organization. So even at a global level, countries were looking at the economic impact of illness. And that term was derived, and now we use that term in order to quantify how much time, how much productive time is lost as a result of illness, and in particular as a result of mental illness. And basically, mental health conditions account for up to 13% of the what we call the global burden of disease. You know, people tend to think that it's the heart attacks and the asthma and the high blood pressure, and those are the things that cause lost productivity. But a whole lot of lost productivity, as much as 13% of the global burden of disease. And that was 2010. And we expect that the 2020 figure would be higher. Okay, so that it's really important. Depressive disorders alone can account for more than any other cause, more than any other disease process in terms of its contribution to the years lost to disability. Globally, more than 300 million people are affected. So this slide shows you a list of the 10 leading causes of lost productivity. And as you would see, major depressive disorder is the second one, and anxiety disorder is number 7. And that's according to 2010 statistics. And as I said, when this is revised for 2020, we expect that depression will probably overtake the back pain. So let's talk a little bit more about depression specifically, and then we'll go on to anxiety. There are different types of depressive disorders. The most common is what we call major depressive disorder, and there are others like dysthymia, substance-induced depressive disorders. In other words, you're taking some kind of medication, and an adverse effect of the medication is depression. In addition, there are medical conditions such as low thyroid hormones, hypothyroidism, that can also cause depression. And of course, there are others that are less common. What exactly is major depressive disorder? Well, to diagnose major depressive disorder, you have to meet specific criteria that are outlined in what we call the DSM-5, the Diagnostic and Statistical Manual of Psychiatric Disorders. That's what psychiatrists use to define and diagnose different disorders. And I've put up the DSM-5 criteria for a major depressive episode so that you can have an idea of what we're talking about. Basically, such a person is depressed most of the day. They're almost always depressed. When children and adolescents, you see more irritability than sadness. And they lose interest in pretty much everything that they would normally have enjoyed. They don't find pleasure in anything. They stop socializing, stop, taking part in entertaining activities. If you're a footballer, you don't have no interest in your football. If you're a student, you can't motivate yourself to study. It basically drains all your motivation. There are also weight or appetite changes, either weight loss or weight gain. Similarly, either appetite loss or appetite gain. There's sleep dysfunction, so you may be unable to sleep, or you may be sleeping all the time. Some depressed people just stay in bed all the time. People can sometimes become agitated, what we call psychomotor agitation, or on the opposite side of that, you could get slowed down. So sometimes people are walking slowly, doing everything slowly, and you wonder what's going on. And it's really because they're depressed. Energy level is low. People feel worthless. They lose their sense of self-worth. They feel inappropriately guilty. They blame themselves for things that aren't necessarily their fault. They have difficulty thinking and concentrating, or they may be unable to make decisions. And then, of course, the most serious of all these symptoms is the fact that there tends to be that preoccupation with death, which, if it's not treated and managed in time, can progress to suicidal thoughts, which can progress to suicidal plans and actual attempts on the part of the individual to end their life. So that symptom of suicidality highlights the importance of recognizing depression and treating it early, so that you could either prevent the person from getting to that stage, or if they're already at that stage, provide the treatment that they need before they actually attempt to harm themselves. And this picture just gives you an idea of what a depressed person might look like. That's sad look. It's important to know that depression can affect anybody. It doesn't matter what age you are, gender, class, it can affect anyone. It's also important to know that children can also be affected by depression, as in the case of many other mental health disorders. However, in the case of children, the symptoms are sometimes expressed very differently from in adults. So instead of that sad face, the child might be smiling as usual, but you might start to see behavior changes or irritability. A child who is normally, potty trained and doing well in that regard may start back bedwetting. So those are the kinds of changes that we sometimes see in children. And unfortunately, children who are depressed sometimes don't get the help that they need because people don't realize that they're depressed and they don't have the words to express what's happening with them. And of course, sometimes they live in places where help is not easily available or accessible. And this slide just gives you an idea, just to show you that for children, attention deficit disorder is the most prevalent mental health condition, followed by mood disorders, including depression. Or before I go on, if you look further down that slide, you will also see that anxiety disorders are quite prevalent in children as well. Who is affected when someone is depressed? Well, basically everyone. The person may be affected, but of course their family members, their friends, their colleagues, everyone around them is depressed because is affected, because they're not themselves, they're not enjoying life, and they're not fun to be around at that point in time. And if they lost their motivation, they may not be fulfilling what people assume to be their responsibilities. How do we treat depression? Well, we treat it, the treatment is twofold. There's medication that we call antidepressant medication, and then there's psychotherapy, what we call talk therapy, which can take place individually or in groups, and there are different types of psychotherapy. There are also what we call the creative arts therapy, like art therapy, music therapy, dance therapy, and things like that. That can also be quite helpful. What is important to note is that research has shown that the combination of medication and psychotherapy can be more effective than either one on its own. Before we leave depression, I just want to touch on bipolar disorder a little bit. And to understand bipolar disorder, you have to understand what is a manic episode. And a manic episode is when somebody's mood swings in the high direction. So in depressed mood, the person's mood is very low, and in a manic state, the person has this elevated, grandiose frame of mind. They don't feel to sleep, they're talking all the time, their thoughts are racing, they're distractible, they're hyperactive, so they're overdoing things, and sometimes that could be harmful because there could be increased spending or inappropriate increase in sexual activity, increase in all kinds of activities that can be harmful if it's not managed in time. And as I said, excessive involvement in activities that may be pleasurable but have a high potential for painful consequences. And this graphic just shows you an animated version of a manic episode. So it basically, bipolar disorder is a psychiatric illness in which people can have both depressed mood and manic episodes. So at times they are depressed, at times they can be manic. Once you've had at least one manic episode, you qualify for that diagnosis of bipolar disorder, whether or not you've already had a depressive episode. The bipolar disorder, there are two types, bipolar 1, bipolar 2. You don't have to trouble yourself with all of that. The distinction is simply that the bipolar 2 disorder, the person has had at least one, what we call hypomanic, in other words, just a little lower than a full manic episode. Yes, the symptoms are the same, but they're not as severe, they're not as disabling, and they're less likely to cause the person to need, for instance, to be admitted for hospital-type treatment. It's also important to know that in people who are prone to developing bipolar disorder, some antidepressants can cause them to swing from the low mood to the high mood. So that is something that as physicians, we have to manage carefully. How do we treat it? Similarly, medication and psychotherapy. And the medication for bipolar disorder is predominantly mood stabilizers, but sometimes we have to add the antidepressants, the antipsychotics, or the sedatives. And we move on to anxiety disorders, which is the other main part of our presentation today. And I found a few anxious looking faces just to remind us what anxiety can look like. But I'm sure everybody has been anxious at some point in their life. In fact, all of us experience anxiety from time to time. Anxiety is that diffuse, unpleasant, vague sense of apprehension, and it's often accompanied by physical symptoms such as increased sweating, increased heart rate, and sometimes a mild stomach discomfort or a mild restlessness. Now, anxiety is not the same as fear. Fear is focused. Both are alerting signals. Both types of emotions put us in that alert state. But fear is a response to something specific, something that is known, something that is external, something that causes some kind of conflict. On the other hand, anxiety is in response to something much more vague. It's unknown, it's internal, and it's usually non-conflictual. Fear is, in other words, fear is a response to an actual danger, whereas anxiety is a response to an impending or anticipated danger. You think something is about to happen, or you think something might happen, and you're reacting to that as opposed to something that is right there in front of you. Anxiety, some degree of anxiety is quite normal. As I said, we all experience it from time to time, and it's viewed as adaptive, which means it helps us to adapt to certain circumstances. You have to sing, you stand in front of a stage, you look down in the audience and you see crowds of people. You feel a little bit anxious. But for most performers, that puts them in a mental state that helps them to really, push for the best and try to do their best and try to impress that crowd. It brings out a small amount of anxiety could actually bring out the best in us sometimes. On the other hand, if it's excessive, it does the opposite. I think I missed this. Right? If it's the opposite, if it's excessive, it's what we call maladaptive. So instead of just preparing us to function, it causes us to feel so unwell that we're actually incapacitated and we cannot function the way we ought to. Just to go back a little bit, I just want to highlight that it prepares us to take the necessary steps we need to take in a dangerous situation, right? What we call fight or flight. If you see a barking dog, you want to either run or do something about it. If you think you're brave enough, you might want to take on the dog, but most of us will choose flight in that situation. And that preparation is accompanied by certain physiological changes mediated by specific parts of the brain, and I won't go into the details of that. This one talks about the specific physiological changes again, but suffice it to say that what we feel as a result of those physiological changes are increased heart rate, increased faster breathing, muscles get tense, and blood flow is diverted from the abdomen to the brain and to the muscles. And the reason for that is obvious. You need all your energy to prepare you for running or doing what you need to protect yourself. In the situation where it is maladaptive, it does the opposite. So it causes you to feel ill. There's that lightheadedness, nausea, diarrhea, sometimes frequent urination. And I don't know about you, but I've felt like that before exams many times. But if you're not able to manage it, then it can affect your physical health and your mental health. There are different types of anxiety disorders. There are panic disorders. There's phobias where you're afraid of something specific. People who are afraid of spiders or afraid of heights, things like that. There's obsessive compulsive disorder where people are, prone to do certain things repetitively and have repetitive thoughts that they're unable to control. There's post-traumatic stress disorder, which is a reaction to a very severe stressful event, such as being, being robbed or being attacked, being in an accident, things like that, things that are outside of the realm of our normal range of activities and that cause tremendous stress. And then there's generalized anxiety disorder, which is the most common one. A little bit about panic disorder because it's very, very common, and it's basically recurrent, unexpected panic attacks. You're having them at least once a day, or sometimes it can be as often as once a day, or it could be once or twice a year. It varies. It's not due to some substance, so it's not marijuana or cocaine or something that's causing it. And it's not being caused by a medical illness. It's a specific neurochemical change. And you experience panic attack, palpitations, heart is racing, you're sweating a lot, you're trembling or shaking, there's shortness of breath. Person might feel that they're choking, having chest pain, upset stomach, abdominal pain, things like that. So the symptoms can be quite disabling. All right, and there's some more symptoms. I won't go into all of them because I want to finish in time to give you some time for questions. Panic attacks tend to come on suddenly, and the sense of anxiety builds very quickly to a peak. Sometimes within about 10 minutes, the person is really, really anxious. And it can be accompanied by a sense of imminent danger. It's like feeling as though something really, really bad is going to happen, as though you're going to die, or as though you're going to be destroyed or harmed in some way. And you feel unable to escape that situation. And panic attacks could occur in several different anxiety disorders. So panic attacks by themselves are not a diagnosis. Panic disorder is a diagnosis. So a little bit about generalized anxiety disorder. In generalized anxiety disorder, people have a persistent sense of feeling anxious. They're anxious all the time. It's different from panic attacks where you have this sudden peak. In generalized anxiety, it's just like a baseline sense of worry and anxiety all the time for at least 6 months. And the person is not able to control it. And it can be associated with feeling restless or on edge, getting tired very, very easily, having trouble concentrating, feeling very tense in your muscles, and it can cause difficulty sleeping. How do we know when somebody has recovered from this type of disorder? Their symptoms have been eradicated and they're better able to function. And it's very critical in treatment that we find a medication for that person or a combination of medications where necessary. So in such a way that the person has few or no side effects. Because if you're not able to tolerate medication comfortably, you're not going to take it for the long haul if you need to take it for a prolonged period of time. In other words, compliance becomes a problem. And for some people, these disorders can be long-term disorders. Sometimes people have it, they get treated, it goes away and they never get it again. But some people need to be on long-term treatment. So it's very important that, it's very important that, sorry about that. It's very important that they're on medication that they're comfortable with so that they can take it without even thinking about it. I tell patients, you know, if you have to be on medication for a mental health disorder, please treat it like you would take medication for any other disorder. Better to take it and enjoy total normal quality of life than to not take it and be disabled and not able to function and have your quality of life be less than it ought to be. So that's all I'm going to share for now on anxiety. But whenever I talk about mental health disorders, I like to talk a little bit about stigma and discrimination because it's very, very common. Most people don't want to be diagnosed with any kind of mental health disorder because they're afraid of being stigmatized. They're afraid of people treating them badly. They're afraid of their friends cracking jokes about it or saying, you know, cruel things about it. And that often prevents people from seeking treatment in a timely manner and causes them to suffer unnecessarily. According to many researchers, persons with mental disorders often say that the stigma attached to having a mental illness could be worse than the illness itself. And that was published in a 2013 article in the Lancet. So how do we deal with stigma? We deal with it by educating people. In other words, to the extent that you can help somebody to understand these things better, you do that. But first of all, you educate yourself. You'll get to understand as much as possible about whatever disorder you've been diagnosed with so that you understand what's happening to you and you understand what your treatment process would look like and you work with your doctor to get there. When I'm talking about stigma, I like to remind people that mental illnesses are brain diseases and the brain is an organ of the body just like any other organ of the body, so they should be treated no differently from hypertension or diabetes or asthma or heart disease. Somebody with a mental health disorder should not be made to face discrimination or should not be stigmatized, whether it's in the school, in the workplace, or in the wider community. Interestingly, in recent time, we've been seeing some celebrities speaking out about their depression, speaking out about anxiety, speaking out about many other mental health disorders. But the ironic thing is that when celebrities talk about it, they're treated as heroes. And when the ordinary person talks about it, sometimes society is very cruel and the person is shunned and taunted and abused, and that ought not to be. And that is why those of us working in mental health are so passionate about addressing stigma and addressing it in a head-on manner. And ordinary citizens can be the most powerful advocates for fighting stigma, so that I say to persons who have been diagnosed with a mental health disorder, the same way you can stand up and say, look, I have asthma, but I'm taking my asthma medication and I'm beating it and I'm doing well. You can say, I have depression, but I'm taking my antidepressants and I'm beating it and I'm doing well. Nobody is allowed to stigmatize me. Nobody is allowed to discriminate against me because I deserve better than that. Okay, and when people speak out, those who would want to discriminate against them or stigmatize them tend to back off because they realize that that is just not acceptable behavior. How do we cope? regardless of which mental health diagnosis we're talking about, there are certain things that help us in terms of managing ourselves and reducing the risk for illness, as well as recovering quickly and maintaining our recovery. And those are very simple things like healthy lifestyle, diet, rest, exercise, and of course your spirituality. That's an important part of who you are. I know that I'm speaking to a very diverse range of faiths today, but regardless of what background you come from, people's faith has been known to help them to be resilient during difficult times. Manage stress if you're going through something that is difficult. Get help if you're not managing it well on your own. Talk to somebody. And you know, when mental health providers talk about mental health services, we like to use a diagram of a pyramid or a triangle, where at the base we have what's available most easily, and at the tip of the pyramid we have the things that are less available and usually more expensive. And the things that help people that are at the bottom of the pyramid are the basic things like taking care of yourself, being connected to your community, talking to people in your community who can help you, whether it's a teacher, whether it's a guidance counselor, a social worker, a peer counselor, the people in your immediate environment who can assist you when you're going through a difficult time. And then we go up the pyramid to the health center and then the hospitals and things like that. The aim is not to get to the hospital if possible. The aim is to get the help at the lowest level that you can get it at. But at the same time, not to be afraid if you need to get a higher level of help, if you need to get a more specialized level of care. And of course, very important, recognize symptoms. If you're experiencing something, if you recognize a change in your emotional state, in the way you normally cope with things, in how you're feeling, if you're having trouble sleeping, or you're losing your motivation, or you're having trouble with your appetite, whatever it is, go see a doctor. Start with your general practitioner and, you know, let them have a look at what's happening with you. They may be able to help you themselves. If they think that you need to be referred for additional help that they can't provide, they will most certainly do that. Where can you get help? And please note that although my picture is in this slide, this is not an advertisement for my private practice or anything like that. You can get help through the clinics run by the regional health authorities, where you will find psychiatrists, psychologists, social workers, occupational therapists, psychosocial rehabilitation staff. If you're in school, there are guidance counselors or school social workers for the children. In the private sector, there are employee assistance programs in most workplaces, and they can refer you to psychiatrists or psychologists if that is needed, so that the same range of services can be available and are usually available in the private sector as in the public sector. In the public sector, of course, it is free of charge. In the private sector, of course, there are costs attached. But if it's through your employee assistance program, then the workplace tends to cover the cost of your care. So it's important to know when, if you're, for instance, a peer counselor talking to a student who is going through something like this, it is important to know when to refer that student to the health center. If it's more than you think you can manage, if you're beginning to feel overwhelmed, or you're beginning to emotionally absorb what's happening with that person into your mental space, it's time for you to step back. It's time for you to refer that person. If that person is having suicidal thoughts or anything of that nature, don't try to do that on your own. Make sure you refer that person. As long as there are medical symptoms, changes in their health status, that person needs to be referred to a healthcare professional. So I think that was my last slide. Yes, it was. So thank you for your attention, and I'll now make myself available for any questions that you might have.
Hello, Dr. Othello.
Yes.
Okay. First of all, nice to meet you. My name is Arjuna, and I'm an engineering student.
Uh-huh.
I am diagnosed with bipolar disorder for 4 years now, bipolar disorder 2.
Uh-huh.
I've been hospitalized. I've had hypomanic and depressive episodes. I have tried to hurt myself, that kind of thing. I'm on medication, like you mentioned. I've passed through about 10 different tablets before I arrived at Seroquel, if you know what that is.
Okay.
Yeah.
Yes,
Yeah.
yes.
I have 2 questions for you. I believe that I am destined to take medication for the rest of my life. And I feel that, you know, my parents have to check in on me, you know, so many times for the day. And they don't want to give me my medication, even though I am an adult.
Wow.
I have to,
Okay.
yeah. So my first question is how do I come to terms or accept the fact that, you know, I have to take these colorful tablets every day to stay sane? And you know, I tell my parents that, you know, I'm big enough to take my own medication, but they don't trust me. So my first question is, how do I, you know, come to terms with that? Or any advice you have?
Okay, thanks, Arjuna. Thanks for that question, and thanks for being bold enough to share your story, because that's very powerful for others listening. Couple of things. Thanks for being willing to take your tablets, because sometimes persons in your situation have difficulty and accepting that they need tablets, and you seem to have accepted that, but you accept that you need it now, but you're wondering if you have to take it for the rest of your. In fact, you said you have to take it for the rest of your life, but you're having difficulty coming to terms with that. My approach to that is to, like I said during the presentation, to treat it no different from hypertension or diabetes. These are chronic disorders. They are chronic, what we call chronic conditions. In other words, there are conditions where we do not have a specific cure that once you've taken a course of tablets and you've finished that course of tablets, you will never get this illness again. You can say that about an infection, and you take some antibiotics and the infection is gone, and that's the end of that. However, bipolar disorder is a chronic disorder, and unfortunately, it is a lifetime disorder. So that you have to see yourself the same way a diabetic or a hypertensive person sees themselves, and you have to understand that, look, there's nothing bad about taking tablets. There's nothing wrong with taking tablets. The most important thing is my quality of life, okay? You're an engineering student, which means that you're a very intelligent person, you're a high achiever, and most likely, I'm pretty certain that you have everything that it takes to have a wonderful career. But what will determine whether or not you have that wonderful career is whether or not you stay on your medication. Because as I said during the presentation, if you come off your medication, the symptoms could be very disabling. They could interrupt your study, they could interrupt your work experience. So that, as I said, thanks for sharing that. And with respect to your parents, I suspect that they're trying to be protective. Parents tend to be very, very protective, sometimes a little overprotective from the point of view of the child. But I'm sure there will be a time when you will have to take them for yourself, because I suspect they give it to you because you still live with them. At some point, you may have to live on your own, and then you're going to have to take that responsibility for taking it yourself. And I hope that you will, when that time comes, you will fully live up to that responsibility, so that they would be able to relax a little bit more and be comfortable in the knowledge that you're going to stay on your medication. And when you have to take it on your own, still check in with them regularly so that they know that you're doing well. And that would keep them, you know, feeling more relaxed. Also, if you're not doing well for some reason, because sometimes people taking their medication and they still have hiccups, check in with them, check in with your doctor early. Don't wait for it to get really, really bad. Because there are times when we can do things in the early stages of a relapse to prevent it from getting more severe. Okay, so I hope I've answered all your questions, Arjuna.
One more, Dr. Othello. As we're on the topic of family, I spoke about my parents being very caring and so on, but we also spoke about discrimination. I do have family members who say things like, get your head in order. They'll tie you down in the hospital. Use a big man, you can handle yourself. That kind of thing. How do I deal with that stigma and that kind of stereotype that you're a madman?
Yeah.
Even in my own family, and being a male person as well.
Yeah, the first thing is to settle in your mind that you are not a madman, so that you don't allow their behavior to affect your self-worth, your self-esteem. So you have to settle that within your mind. You have an illness, but you now know that with medication you can live a full life.
Yeah.
And you have to keep saying that to them until they get it.
Yeah.
Right?
It's not everybody, yeah?
I'm sure about that.
It's not everybody. Some people are very supportive, but some people are, yeah.
Yeah, and do your part, educate them about stigma. Let them know what stigma is. Let them know that what they're doing when they say those things to you is a stigma.
Yeah.
And that it's unpleasant and that you don't appreciate being spoken to that way. And you would prefer, sometimes we have to get real with people and say, look, if you love me as much as you say that you love me, please don't treat me that way.
Yes.
Okay.
Yes. But on the good side is, I work with Hannah Benjamin. I have been exercising. I've been keeping a good diet. I have been praying. And I am sticking to a good routine with my timetable and so on. So I am working on myself, but I appreciate the advice. Thank you very much. And thanks to everybody in the chat as well. God bless.
Juna, all the best.
Thank you so much, Juna, for being brave enough to, identify and to share and to educate as well. I really appreciate that. And I'm seeing the comments in the chat. People are supportive of you, and we're hoping that we will have that continued support for you, because I think that's what we need, support. Before we take any other questions, I just want to indicate to you that I've placed my email address in the group chat. If you have any questions after we've run out of time, please send them to me and I'll forward them on to Dr. Othello, because we have, let me see what time it is. It's now 1:48 p.m. We have 10 minutes remaining for question and answers. So at 1:58 p.m., one of our students will be saying the thank you. So if you have questions, kindly ask the questions. But if we run out of time, send me an email. Send me an email, please. So we are open for questions until 1:58. Feel free to ask Dr. Othello your questions.
Good day, Dr. Othello.
Good day, Russell.
Just for some small clarification. Many years ago, I did some international traveling, and I met somebody for the first time who they told me they were manic depressive. Not knowing what it meant at the time, I asked for some clarification, and they told me that sometimes they were very happy and other times they were very sad. On my return to Trinidad, I was speaking to somebody about it, and they told me, but they don't know it as that, they know it as being bipolar. Is there a difference, or is it the term used interchangeably, one? And two, does it have any relation to autism on that spectrum? Thanks much.
Okay. All right, the second question first, it's not related to autism. Autism is a developmental disorder, which means that it starts to manifest itself as an infant begins to develop, and the symptoms become more clear as the child gets older. But this is very different. But so it's not autism. Having put that aside, yes, bipolar disorder is the same thing as manic depressive disorder. It used to be called that more commonly some time ago, but the DSM-5 refers to it as bipolar disorder now.
Thank you.
You will also hear people call it bipolar affective disorder. That's another terminology.
Dr. Othello, I want to jump in here quickly and ask you a question. as an international student, or at one point in time as an international student, and there was this Chinese student who was pursuing a PhD, and in one of her taught courses, she got 87. And, you know, she jumped off a bridge, fell into a roadway, and she was killed by a passing vehicle. And, you know, my colleagues and I from the Caribbean, we were saying, you know, had that been us with 87 marks, we would have been somewhere celebrating, right? It's only years later I started to probably understand why someone would take such what I term a drastic act. Could you just share some insights as to what could have possibly led to that?
Okay, suicide is always very unfortunate and very tragic. And the causes that would lead a person to end their life are diverse. There's so many different things. In a situation like that, I mean, we can only speculate, but it is quite likely if you, from what I know of the Chinese culture, there is a high demand on achievement, right? So that people want to excel, they want to achieve. Remember, they have their population measures where a family could only have one child, and they want the best out of that one child. Opportunities for academic advancement are limited. So when you get that opportunity, you want to make the best of it. We don't know where this person came from, but they come from a remote province and now they're in university. And I remember when I was applying to medical school, I thought about, you know, I was looking at different campuses and so on. And when I was looking at universities in Canada, I realized that it was hard for international students to get in to Canada, to medical school in Canada. But the small number of international student spaces in Canada, 99.9% of them went to persons from China and Japan. In other words, they excelled to the point where nobody else could get those spaces. So they push themselves to certain limits and so on. But the unfortunate cost attached is that I like to tell people disappointment is a function of expectation. So in your case, if you were working to, if you're hoping to pass, and you tell yourself you'll be a little happier if you get a lower second, and if you get up a second, well, great, and you had no expectations of getting a first class honors. Then if you get an upper second class degree, you're on cloud 10. But if you spend your whole 3 years on campus working for first class honors because your parents expect that of you, or because society expects that of you for some reason, based on the background you come from, then if you get the same upper second class honors, it could seem catastrophic. And I make that example because I want to stretch it a little further in terms of how we treat children in this society, particularly around exams, essays, CSEC, CAPE. We have a culture of parents living vicariously through children, and parents wanting to make children, you know, saying and doing things that perpetuate the idea that if you don't get a scholarship, you have failed. Unfortunately, in some of the prestige schools, that's a very prevalent thought pattern. My sister, who is a teacher, was saying just the other day that when she sees a class with 24 out of 28 children get scholarships, and she's a principal, her thought goes to the other 4. What are they thinking? What are they feeling? Are they feeling like a failure with their 4 A's at CAPE level? Because on a breakdown, they got a 2 in something and they didn't get an open scholarship. Everybody can't get 100%. Everybody cannot get the best results on the face of the earth. Right? I have absolutely no shame in admitting that I have failed some exams in life, but they didn't destroy me. So that the approach has to be that adversity is just another hurdle to get over, and that once you've done your best, hey, your best is good enough. Somebody else's best might be 100, that's their story. Your best is 87, that's your story, and enjoy your story and enjoy your life.
Okay, thanks for that, your response, Dr. Othello. We have time for one other question, please. We have anyone who's willing to ask a question? One question?
Yes, good afternoon. Are you hearing me?
Yes.
Yes, good afternoon, Dr. Othello. I'm a guidance officer, Jillian Garcia. Hi, Dr. Wallace as well. My question is this. In your experience, would you say that people tend to mix up mental illness with spirit possession? Because this has come up in my own dealings with students in my schools. And people swear that their children are possessed when it may very well be a mental illness or a mental health concern. Thank you.
Thank you for that question. It's an excellent question because it's a part of our culture. Unfortunately, within our culture, mental health disorders are quite commonly perceived as spiritual problems. I have no difficulty with, you know, if a person with a mental health condition wants to be prayed for, I mean, why not? If you have if you practice your religion and you want somebody to pray for you to help, that you would feel better, that your illness, your symptoms would go away and all of that, that's great. But to refuse, the challenge is when people refuse treatment or refuse to access treatment based on the expectation that this is only a spiritual problem and this is not a mental health condition. So my advice is usually practice your religion, do what you're accustomed doing, but understand that there are certain symptoms that doctors understand, that there are certain things that have been studied, we know what it is, and we can treat it. I also throw in this bit. There's a bit of stigma in that as well, because nobody tells the person who says my chest is hurting me that it's a spirit. You get that person to casualty because you're afraid it might be a heart attack. Mental illness, we stigmatize sometimes by calling it demon possession. We stigmatize that person. Because how do you feel if you're a mentally ill person and instead of being assisted in getting treatment, people are calling you demon possessed? I'm sure that doesn't feel very good, right? And unfortunately, some of the rituals that people are put through in attempts to get rid of demons could be quite sometimes dangerous. So that practice your religion, believe that God can heal you. I believe that too. But understand that God has given wisdom to human beings. The wisdom that we received in our medical training, I personally believe all the wisdom comes from God. I don't believe we could make it up for ourselves. So use what God has made available to you in the form of your doctors and your treatment team, your psychologist, your social worker, your whoever, and let them help you.
Okay, thanks a lot for that response, Dr. Othello. At this point in time, I would just like to say a brief thank you to Dr. Othello, and thanks to all of our participants. Thanks to June and others who shared their stories and who asked questions and commented. I've placed my email address in the group chat. If you have any questions whatsoever, feel free to send them on to me. I will pass them on to Dr. Othello and ask her to kindly provide some answers to me. At this point in time, I'd like to hand you over to one of our students at the Faculty of Social Sciences, Ms. Kira Alexander, to move a vote of thanks. Kira?
Good afternoon, everyone. I hope you all are hearing me. Dr. Othello, we would like to thank you so much for this afternoon's presentation. It was wonderful, it was educating, and it made us remember that mental health doesn't have a face. You know, all of us, we can experience this at some point in time of our lives, and you know, we always need to be aware of some of the things, some of the avenues that are available for us to always keep in touch with our true selves. Remember that, you know, nothing is wrong with us when we do experience mental health, because it is something that happens to everybody. I would also like to thank our dean for making this possible. I would like to thank some of our lecturers like Dr. Wallace. You know, they always look out for us as students, make us feel like we are not here alone. We have support, we have backup, you know, and I would just like to thank you so much for this presentation. It was wonderful, it was concise, but we absorbed everything that we needed to. So thank you so much.
You're welcome.
Thank you, Kira. This is the end of our session, Dr. Othello. We will speak privately, but thank you, Dr. Othello, for sharing. Thanks to the Dean. Thanks to Karen Harrison. Thanks to Giselle Joseph for putting their work behind the scenes. So thanks to these ladies. Also, thanks to each and every one of you who logged in and as participants. I'm hopeful that we would have had taken away at least one thing. Certainly, I've taken away many things from the presentation, this wonderful presentation by Dr. Othello. But if you were to leave with one thing here this afternoon, then as a university, we would have achieved something. So once again, thanks to everyone for participating. Thank you, Dr. Othello, and have a wonderful afternoon.